You're listening to The Health of Business, where we talk openly and honestly about what it takes to run a healthcare clinic business in BC and Canada today. I'm Danielle Boyd, and I'm glad you're here. So, Cassie, welcome. I would love if you could kind of just give a little background as to your story as a physio and where you're at now in your clinic. Yeah, just give us a little background.
Well, hi, thank you for having me. So my name's Cassie. I am born and raised Victoria, Vancouver Island. I played high-level soccer as a kid, so I knew I wanted to be a physio since probably the age of 12, 11, when I was first introduced to the profession as an athlete. And it's something I always gunned for as a teenager. And then I played high-level soccer. So I was kind of aware of what was going on in England with my connection there, ended up going to play over there. And physiotherapy is faster over there. So you don't have to do
Mm-hmm.
your generic bachelor's degree like you do in Canada. So I ended up doing a bachelor's of physiotherapy, which is a 3-year degree. I then worked for a year, and then I went back and did a kind of more sports MSK focused master's to make
Oh,
myself eligible eventually at some point to return to Canada.
I
Yeah,
see.
so
Oh, so there's like a different, like it seems like you kind of get like a base level physiotherapy degree and then specialize within that.
yeah, you
Interesting.
can do a general bachelor's and then do your master's of physio. They have kind of different physiotherapy master's degrees. So we call it like a post reg or a P reg. So basically, are you kind of coming in as a physio? Are you coming in not as a physio, wanting to be a physio? And then they kind of accordingly do the master's program accordingly. Yeah. So you get a
Oh,
lot of
interesting.
Canadians will come over and do their post reg physio master's degree over in the UK. So
That
there's a
makes
few
sense.
universities now that actually specialize in Canadians coming to the UK, and then they've built their networks to help support them get back. So Glasgow actually is a big feeder for Canadian physios, and the University of Brighton is a big feeder for Canadian physios.
Interesting. So they've kind of just honed the course that is needed and they've kind of adapted themselves so that they can train Canadians and make sure that they're prepared to come home and to write the exams and become registered back in Canada. That's a great business model, really.
Oh, very much so. And they kind of tweaked like how many hours in certain specialties they need to qualify, for the credentialing service and all that kind of stuff. So they really kind of cater. So when I went through the program, it was just starting. I went to Brighton, not for that, but for other reasons for my master's, and they were already starting to tweak it. So I think there were 4 of us that were going through at the time. Um,
Interesting.
they all
Yeah.
went back. I stayed because that's not why I did the program. I ended up staying because my husband's English, so I stayed here and worked for 6 or 7 years in London, in a, very much like a sports medicine, post-surgical role, so working very closely with the surgeons, doing intakes with the surgeons and appointments and that kind of stuff, where the people I trained with, they went straight back to Canada.
Got it. Got it. Okay, so that's super interesting. I'm really curious to hear about your time working in the UK and London. Like, that's a really interesting model where the physiotherapist is working in tandem with the surgeon, doing intakes, doing like working in parallel with that, because we typically here see post-surgical only. Like, we're not going through that entire journey with the patient. That's really cool. I'm curious to hear a little bit more about that.
Yeah, I mean, I'm biased because I've worked in it for many years. I think it's a fantastic model. I have to say, probably one of the most frustrating hurdles coming back to Canada is the disconnect between the surgeons here and the physiotherapists. It's very frustrating. I've had a few kind of DVTs and post-surgical infections and stuff that have been picked up, and some post-operative complications that have been picked up since returning home. And my only after trying to hammer down doors and call MOAs, at the end of the day, end up most of the time sending them to A&E, which is very frustrating for them and for me and for the surgeon.
Yeah.
Where in the UK, so you can graduate, you do most British trained physios will do their 2 years in the NHS. There's kind of a allegiance to the national service. So they basically do your 2 years of rotations. So it's basically like still being a student. You're very much supported. You do 6-month rotations. And it's a great learning opportunity. There's placements you can't do as a student that you can do as a junior physio, like oncology and peds, that you get to rotate and gain experience through. So I did weekends and evenings doing that so I could kind of keep that experience. But then my primary role was my 9 to 5, Monday to Friday, was working in the downtown city of London, with a MSK private practice clinic who specialized in more of that sports medicine surgical. So our company worked very closely with the big surgical centers. So we would do preoperative care. We would go in with complex patients and do kind of collaborative surgical assessments.
Whoa.
Um, we sometimes would go in and watch the surgeries, which was super cool. If there was, interesting things going on, or if the surgeon was kind of going in because we didn't really know what was going on, we would kind of occasionally go in and watch those. And then we would do their post-operative care. And the lovely thing about it is all the surgeons were, a WhatsApp away. So it was,
Oh,
we've been doing this week. It's not going great. What are your thoughts? And they would go, let's consider X, Y, and Z. Maybe we tweak, we do this. And you say, great, I'll be in touch in, 3 weeks, or, if something comes up. So it's so collaborative, which is amazing for the patient. As we all know in this industry, the lag for the patients in BC is probably, for me, what's the most frustrating. Like, knowing this patient has knee OA or a meniscus or an ACL tear, and I find them challenging to treat. It's changed my entire approach to physio, because in the UK, if they needed a knee replacement, I could have them in with the surgeon on the Friday. They would do their pre-op assessments and they could be having surgery within 2 weeks.
wow.
Um, so you're very much following more your researched protocols. So,
Yes.
we can do an ACL replacement when they've got full range of motion and their muscle strength is at a 90% capacity to their, uninjured leg. That's the protocol for preoperative kind of threshold for surgery. So that's what we push for. And you're trying to get that as fast as possible. So you treat them very differently. You're getting them in 3-4 times a week. We're pushing them in the gym, pushing them in clinic. As soon as they're ready, they're having their surgery. Where in BC, it's a little bit different. Um,
Very
you're
different.
you're playing the long game. So,
Yeah.
as we all know, we're all very busy. So the ability to pull physios in or pull patients in 4 times a week in my schedule, that's virtually impossible. In England, you have that flexibility. Um, if you were booked 4 or 5 weeks out or more, that's not a good sign. They would view it as an inability to manage your caseload. And you're not discharging appropriately, you're not discharging fast enough, you're not doing your job effectively enough. From my experience being back in BC, some physios pride themselves, not all, but some pride themselves on how big their wait lists are and how big their case, how long people wait, which to me is a massive negative, and it's not something we should aspire to. Um, the way I train all my guys is treat them and street them, get them in, get them out,
Yeah.
appropriately. But also that's just so much harder to do here because the surgical lists, I've got at least 20 patients on my caseload right now that we're just managing, waiting for surgery.
Yeah.
So we connect every 4 to 6 weeks. We check in, we progress, we change, but ultimately, there's no discharging, there's no treating and streeting, because ultimately we're waiting for surgery. So it's a very different model
Exactly.
here. Yeah.
Wow, that's like, I mean, just that like small little snippet, like look into it is wild because first of all, I love the fact that you're following the patient pre and post. That's huge. In BC, it's a completely different, like the people who are assessing pre might be the same as post if they just choose the same clinic, but it's not this like, collaborative, like same unit, like you're working in the surgical division of the hospital alongside the surgeons or alongside the rest of the whole team, the physicians and nurses, whoever. But you're right. Like we do pride ourselves on being super busy because it feels like this like demand thing. People, like my skill set, they like my, whatever it is that I'm doing in terms of interventions. But you're right. Like so much of it is people are booking for 6 weeks in advance because they're like, well, I'm not getting surgery for 9 months, so I might as well just book weekly in the interim. And that makes us feel really good. But we haven't achieved our goal because they haven't, gone through the surgery that they're requiring, or, they are not like, it's just kind of status quo. And that's a really interesting difference. Wow. And yeah, you're right. Like it's not effective. It's not the same, or I mean, it's maybe effective in managing, but you're not streeting them. I like that.
Let's treat them. Yeah. And I
Yeah,
mean,
streeting
that's
them.
what we're here to do. We're here, physio is here to make people better. And so until we work on our surgical lists and our wait times, which I mean, don't get me wrong, the NHS, the English system is not all that it's cracked out to be. They are equally drowning as we are in the public sector. I am speaking very much to a private sector scenario.
Oh,
If you are using the public sector, then your wait times are slightly better than BC, but they are, you're still waiting a few months for things. That being said, because they have such a wide and well used, well funded, well supported private sector, the private sector over here is massive. And it caters to international travel. I've sent a few of my clients to my old surgical colleagues in London for surgery. So they cater internationally, but there is so much of it going on here that they can really help and support the NHS, for those that can afford it. And a lot of people have surgical coverage under their medical insurance.
yeah, that was my next question is how are they affording that? So that's interesting. So these extended health plans that they're getting in the UK are
Coverage
covering not only physio, but like surgery and other physician related visits.
payments and
Interesting.
costs. Yeah, yeah,
Wow.
exactly. They're covering your preoperative scans, preoperative assessments, surgical recovery, and then your physio on top of that. So it's different. So there's not a massive population that would be outside of that. You've got your students, your seniors, and part of the workforce that won't be covered, but a large part of the workforce would be covered under that.
Wow, that's a different model. And they probably have more extensive coverage than we would here with our classic like Canada Life, Pacific Blue Cross type coverage, I'm guessing.
In terms of physio, they
Yeah.
operate very differently.
Mhm.
In my opinion, I think it's much better than the way we operate in BC, but that might be a different opinion among physios and patients. So they operate in the how do I phrase this? So they operate differently. So if you say hurt your elbow and we're suspecting tennis elbow, you would call your insurance provider. So you call Sun Life. Even if you had unlimited physio under your plan, you don't actually have access to it. You call them and you say, I've hurt my elbow. You'll be on the phone with a physio. They'll do a quick, 10-minute, 20-minute interview and they'll go, okay, it sounds like X. Our national statistics show us that tennis elbow is roughly 13 sessions over 3 months. Here you go. And that's what you're entitled to. And then if you haven't gotten better in that time frame, then the physio would write a report similar to your ICBC or your WorkSafe, bit shorter, but these are the barriers. Here's some yellow flags. Here's some restrictors. This is where the person was on initial. This is where they are now. This is why they haven't met that statistic. They've had to work long hours, or they've had another accident, or, family issues came up. They couldn't participate in physio, whatever it is.
Totally.
Can we have more sessions? And if they have unlimited coverage, I mean, not often, occasionally you'll get, cut off. That threshold is quite high, but they will then allot you another round of physio. And then some. insurance companies, you only have access to 20 sessions a year. So you go through the same process, but once you've hit 20, you're done.
Right.
Similar to your, pots of money, as it were here. But,
Right.
in my opinion, it might be an unpopular opinion, but with the current, issues, we all know what's going on with Pacific Blue Cross and all those that we've all, sat and watched or had to go through. You weed out a lot of that physio that
Hmm.
might be on the edge of what the insurance companies deem as acceptable
Yeah.
because you're going through, I am injured, therefore I am going to physio, not I have physio and I'm just going to use it up for the sake of it. I mean, we all know come November, you get patients coming through and it's like, why are you here? And it's like, 'cause I've got $700 of physio to use up.
Exactly.
I mean,
Benefit season.
which I have a pet peeve around. My view on it is I am busy enough that I try not to take new patients during that season because I don't have the time to see them. And if you're not coming in with an injury, you're basically more of a personal trainer. And I'm all for preventative physio. I'm all for, being strong and, learning about your body. But we all know that's a questionable point with the insurance companies.
Exactly,
Uh,
exactly. Like their scope of coverage, they indicate very clearly that prevention, weight loss, fitness is not covered. And as private insurance companies, even though it's well within our scope, like scope of practice and scope of coverage are two different things, right? So we can
is what we're
absolutely
all
do the preventative work if we want to, but the scope of coverage of a private insurance company is totally dictated by them. And that's on the client and the purchaser of the policy to understand and be clear on.
Yeah. And it's us as well to, we don't know the insurance policies, but I mean, after going through the Blue Cross audits, we all know scope of coverage is very different to scope of practice. And we're all or should all be very aware of that now. And it's up to us to advocate for that. And I think, although it might not be a popular opinion, one way to get around that would be for the insurance companies to change how they access their benefits, um, is how the UK operate, which I quite like. That being said, if the patients want to come in and pay privately and, work on things that have been identified in a physiotherapy appointment that don't come under that banner, patients would come in all the time and pay for that. And they were more than willing to do. And, those are fun appointments. We all enjoy doing that preventative side, but yeah, it operates slightly differently here.
Interesting. That's a cool snapshot. And, like having medical professionals working on their side, now you're kind of like you're peer to peer, right? And I think in the US it's something similar too. Like you have to speak to a medical professional working on behalf of the insurance company. And I think, I'm sure there's scenarios where they don't agree and there's conflict and like that happens. But I do, like having medical professionals actually being able to speak the same language as the treating professional on their side, I think would make a huge difference. Like, I know a lot of people get really frustrated because they're, being told that they have to cut this person off or whatever, but people who don't have that medical background. So there's, like it's really challenging working with an adjuster or representative of an insurance company when they don't actually understand the medical language. So yeah, that's just an interesting difference. Um, so okay, so you worked in the NHS, you worked in private in the UK. What brought you back to Victoria? Because now you're in Victoria. Tell me about what you're doing in Victoria.
Well, honestly, we actually never intended to come back. Um,
Right.
Scope of practice is so much bigger. So prior to COVID, I'd finished my diagnostic ultrasound degree for musculoskeletal scanning. So, assessing shoulders and knees and feet and hands and all sorts. And I was just about to start doing my prescriber's license and injecting license to do your frozen shoulders, your knee aspirations, your PRP injections, and all that kind of stuff. And then COVID happened and I had a newborn at home. I had another one on the way, and work were like, you can't be here. So my husband and I decided that we'd go back to Victoria because being in central London, we knew it was going to get out of hand. And we thought COVID would be 6 weeks. And we all know COVID was not 6 weeks. So we ended up
Yes.
being in Victoria for a year. And by the time, international flights had opened and I'd had our second child, my son, and by the time we got his passports and stuff sorted, we'd actually been here for a year. And at
Wow.
that point, we just thought, you know what, let's stay. We like it here. Our ultimate goal was to raise kids on the West Coast. Let's stay. And
Wow.
so within a week of that decision, my husband and I had agreed that, we loved the way the UK worked in that collaborative environment and working as a team. And it's a little bit different here. And so we decided to open up our own place. So we opened up our downtown Victoria clinic in June 2021, which
Wow.
was quite interesting because I got caught in the caper licensing issues. So we opened a physio clinic with no physio.
My
Um,
goodness.
so that was an interesting hurdle, navigating that. And then a year later, we opened our second clinic, which is more kind of Saanich, kind of Greater Victoria, which is quite exciting. And so we have the two clinics now, which are doing well. And yeah, we're really trying to bring in that UK model. So most of our patients see, two, three, four practitioners. And our goal is really treat them and street them and work together and, bring the best out of every profession and everyone's expertise. We do a lot of in-house training, a lot of in-house MDTs. The expectation is that if your client is seeing other practitioners, that prior to those appointments, you are always connecting with that therapist and giving them the lowdown, because we all know patients hate explaining their story multiple times. Um, and sometimes we will do joint sessions. So if things are really complex, we're not sure what's going on, a few of us will sit in and do a session together so we can rack our brains together. Um, we hired an ND because I can't inject, but I know the value of injecting, working so closely with it in the UK. So we brought in an ND with a sports medicine focus. So she does all of our diagnostic scanning and injecting. So your steroids, your PRPs, your prolotherapy, whatever, just painkillers, whatever's needed. So her, I, and a few of the other physios, we run a clinic together that other clinics refer into, as well as our own team. So, when patients just we don't know what's going on. There's a lot of evidence to show that diagnostic ultrasound is better than x-rays for certain things, not all things, but certain things, and is an eye into what's going on versus waiting for an MRI. So her and I run a clinic together where we do an in-depth joint musculoskeletal exam, and then we'll do a diagnostic scan together, and then, if need be, bring the patient back in for an injection, or, send them back to their physio with better answers and a pathway forwards.
That is amazing. And like, so first of all, I'm blown away that in the UK, physios can have the ability to inject and to do diagnostic imaging. Like, we are so limited in our scope of practice compared to the UK, which is, I mean, that's a whole topic that we can dive into. But
Oh yeah.
I I love that it has been like specialty training for each one of those. Like, it's like a special certification. It's like you don't have to pursue it, but you can. And it's training, and it's like, these specialty silos that you can search and go through and achieve. And now you are certified to do this thing. And, like, while we are fighting this like scope of practice expansion battle here in BC and in Canada, I think having these like specialty trainings and having these, different courses and advanced practitioner level, trainings is essential to having that scope of practice expansion. I don't think opening it up and now physios can just do it should be the way to move forward. I think having diagnostic imaging courses and specialties and licensing is the answer towards that. So first of all, that's like wild. And second of all, that must be incredibly frustrating to come back to a country where you are so, like your training, your specialty, your level of like ability is so advanced. You've done all these specialty trainings, and to come back here now and be like, I can't use them is first of all, like so frustrating. You must still like, because you can still use ultrasound. You just can't like formally diagnose you using it in BC. Is that correct?
It's gray. It's really gray. I've talked to the college a lot about it. Um, yeah, it's gray. I mean, you can like, so, so we all know the physios, like pelvic physios here, are using it as like a biofeedback tool for pelvic floor retraining. Our pelvic physio on site does a lot of that with her guys. I cannot formally diagnose with it. I have to be very careful in how I use it. I don't use it as much as I would have done in the UK. Like, I really only pull it out if I'm kind of stumped. Sometimes I'll pull it out as like an education tool where it's a bit more less gray and a bit more green lit. Here is your anatomy. Here is why things are not getting better. You know, this is what a normal image looks like, and this is what yours looks like. Let's do some
Mm,
strength training. Let's see what this image looks like. You know, in a few months, similar to how the pelvic floor physios are using it. Um,
totally.
it's definitely quite gray, which is why I do a lot of the scanning with our naturopathic physician, because then
Yeah.
it's a little less gray. So
Yeah.
we
And
do
then
it.
collaborative and yeah,
Yeah,
totally.
it's a collaborative thing. So it's definitely something we are, I'm advocating for heavily at the college level, at the PABC level. I agree with you. I think, it was a 2-year degree for me, to do that training. And I don't think that's something that should be handed out. We all, well, not everyone might know, but, an X-ray or an MRI, it's, anyone could take those. You line the person up, you take a picture, you snapshot, it's done. Where ultrasound, it's very much user error.
Mhm.
It's very easy to miss things. It very much comes down to experience. It comes down to exposure. It comes down to, you know, how you hold the probe. It's very much a user error. And so that's not something you can just widely give access to. It's a lot of training. It's a lot of hours of training, lots of exams to know you're on the right track. So it's definitely something we need to be very careful in how we, branch that out if we ever roll it out. But I mean, giving physios the ability to inject, to me, just makes sense. How many times, fortunate we have someone in house. So, I had a frozen shoulder a couple months ago. All the
Mm.
research shows hydrodilation in the first 3 months is the best, standard of care. So, frozen shoulder, walked around. We did an assessment together. She was injected, came back. She's doing great. How much would we all love to have the ability to do it and, to do it ourselves? Um, doing a steroid injection for Neo A to get the pain levels down, to get them to that forever waiting surgical timeline. Like, to me, it just makes sense. You need to put in a lot of gateways and safety nets and exams to allow that. But physios, we've got the anatomy skills, we've got the training, we've got the rehab training. It just makes more sense to me than a GP does. How many times have we heard patients go, "Oh, my hip was hurting, so I went to my GP. They did an injection, and it didn't really help." You know, Injection therapy is a fantastic tool, only if used correctly. And all the research shows that it has to be done diagnostically. It doesn't matter how good of an injector you are. If you are doing an injection blind, your chances of hitting it are 1%.
Yes. Yeah.
And until you
Wow.
see it on ultrasound, you don't quite understand that, but it's so easy to miss structures. Blind injections, there's a huge push in the UK, a huge push across the world. Physios and the medical profession, we shouldn't be injecting blind anymore. There's just no good reason to do that. And ultrasounds are getting cheaper and the technology is getting better. I mean, you can pick up an ultrasound now for like $6,000. We should not be doing ultrasound we should not be doing injections blind. And so then there's that
100%.
whole level of training. But you often hear from patients, I had an injection and it didn't help. And it's like, well, you know, where did they put it? How do they know they hit the right thing?
Did they use an ultrasound?
Was it guided? And so a lot of times I get patients come in and they say, I've heard about you. I'm coming to see you because I had injections. They didn't work. Do the assessment. You say, I guarantee this injection will work. It just needs to be done properly. And so we scoot them around and you do it guided and they get a lot of relief. That being said, injections don't fix everything. But a guided injection can do a lot for a patient. And if physios having
100%.
more access to that to refer into it, or to get, a lot of patients don't need to be on the surgical list. They probably just need an injection, to be quite honest.
Totally.
It can save a lot of that. A lot of times they go to the surgeon and it's like, you just needed a little bit of this and it's better. And so if we can help the medical system by weaning a lot of that out,
Yeah.
doing injections, doing them properly, with the evidence and efficacy that they need, then, we can really help take the strain off the medical sector, which is a lot of the advocacy that I've been doing, um, is how I've learned in, meeting with government and various meetings and, networking is if we're going to expand our scope, they honestly, the Ministry of Health does not care that we want more scope. It really doesn't matter to them. They want to know how we can save dollars.
Yes.
At
Yes.
the end of the day, it
100%.
comes down to the financial line. How can implementing physios save our healthcare money? And
Yes.
if you can answer that question and give them data on that question, then they're more willing to sit down and talk.
Mhm.
And that's why we're making progress, albeit slow, but progress with our ability to eventually, hopefully, ask for the ability to send on for MRI and for X-ray and for imaging. It saves, we all know that health or primary care physicians or GPs are strapped. So this way we can offload by not unnecessarily sending patients to the GP. We all know with that letter, here's your letter, you go to your GP, you need an MRI. And we can bypass that appointment. Well, that is money saved
Yeah.
for the industry. The GPs might not like it, but it is money saved. And so that's where they're willing to sit down and have a conversation. So this is where, as physios, we need to join as a profession and advocate as a profession as where where can we save the sector money?
Absolutely. Absolutely. And you're totally right. That's what they want to hear. They're not, interested in the fact that we have the training and the intelligence and the, capacity to do it. It's about
Or they
making the
don't care what the
system.
other countries are doing.
Yeah.
You say, "This is what they're doing in Australia, this is what they're doing in the UK, this is what they're doing in the States," and they go, "That's great for them."
Cool.
Like, I'm stoked for them, but that really means nothing here. And it's not until you sit them down with the numbers and go, "Look, the NHS is something we should all be as Canadian physios, the NHS, England, it's really what we should be looking to." The NHS is a drowning medical system that has been very nifty and how they can expand various professional scopes to help them. And physio just happened to be at the head of that ship, and how the physio profession has exploded over here in order to support the NHS is something that Canada really should be watching, because they're doing a lot of really cool things here. Physios are doing really interesting things, and it's something we need to push for.
Wow. And I assume they're also saving money. I would be curious to know like
Or
what
cheaper
data
than
they're
doctors.
collecting and
The NHS does nothing without data and evidence. So those numbers, although sometimes hard to find, those numbers exist. So that's been something a few of us have been working on in the background, is trying to pull those reports, find those details, to submit to the Ministry of Health and go, look, this is why they've done this. This is how much money they've saved. And this is how we can implement it. The big thing we're looking at here at the minute, a group of us are working on, is a fracture clinic. So, and it's just getting going. They're doing a trial run in Ontario, which is very exciting because that kind of helps us a little bit more. But there's no medical doctor involved in a fracture clinic here.
Wow. So the physios
Here at
are
UC.
assessing, ordering x-rays,
You come into
casting.
Mhm. Yeah. So if you come into emergency with a suspected broken bone, you'll get triaged to the fracture clinic. They will do their assessments. They will send for imaging. They will read the imaging. They will send to the cast clinic. They will then redo those x-rays. They will do that, treatment care advice that we all learn for our CAPER exams. They will then bring them back in 6 to 8 weeks, take the cast off, do the range of motion, give them their exercises, and then refer on for physio. And if it's a surgical requirement, then they will bring in the medical team for that. But that's, hundreds of thousands of dollars across the country saved by employing a physio to do that role. It's very much within our scope to be able to do that with very little specialist training to be able to run that clinic.
Exactly.
Uh,
And there's not even the only advanced or like exceptional thing within that we're not currently doing is ordering the x-ray. That's the
exactly.
only thing that like the physios aren't currently able to do. And like it just seems so redundant to have to send that patient back to a GP to get that referral who will ultimately just come back to the physio for the treatment anyway. Like it just seems so bananas that that's not an option.
Which is why the PABC is doing such a great job at, their advocacy for that real push. Unfortunately, we had a recent government change, so that's kind of slowed us down with kind of our steam forwards. But the PABC is doing a really good job. They're pushing as hard as they can, where they can, to get that pushed through for us. So, everyone needs to support the PABC big
Yeah,
time.
I know. I know, right? I feel like every podcast episode I've recorded, that's been like the ultimate message. Is like if you're not a member now, be a member because they're doing incredible work.
That's one thing I would say that the UK does very well is over there it's called the CSP, as opposed to the PABC, and they they suck us in from being a student, and it's day one. I was sitting in class, I think I was probably day one actually, and the CSP rep came in and they said, right, get your phones out, you're all registering right now. It lasts for 2 years and then you re-register when you have your license. And because they are such a strong association, they have so much power at a government level to do the advocacy because they are so strong that they are listened to. I think the problem we have over here is there's a lack of community within the physio world here.
Yeah. Yeah.
That's something I really noticed coming back is, clinics are unwilling to be collaborative. And if you're reaching out to physios because they have an interest in something and you want to send your client there, it's kind of like, well, why are you reaching out to me? Like in the UK, it's so much, I guess there's so many more physios here. Maybe that's part of it, but it's much more like, I can't treat this. I don't really know what I'm doing. I'm going to send you to so-and-so because this is, this is what they do. This is what they love. Or, how can we
Hmm.
work together as a team? But because the community there is so strong and it's less of a mine versus you, the CSP is so strong. And,
Yeah.
when they sit down at a government level and ask for things, they are listened to. They've, not all the time, they've had a few setbacks recently, and things taken away from them in terms of scope and stuff like that. Physio's not doing as they should.
Interesting.
But,
Okay.
you know, that's another story. But generally they are very strong. And that's something that the CPA needs support with. So I think everyone should support the CPA, but very much everyone should be supporting the PABC. They are working so hard right now with ICBC, with Blue Cross and the insurance companies, with scope of practice at the government level. The more support they have within our community, the better they can do that.
That. Well, and it's so interesting. Like I'm kind of thinking back to like the model of entry to school, like getting into a physiotherapy program in Canada, like BC specifically was my experience. Like it is so competitive. So right off the hop, it's already this thing that is like, this is scarce. There is not a lot of resource. Like I have to, fight tooth and nail to, get into the school and then get my license and then get this job. And it seems like that's kind of the energy that starts the whole process is like competition. And now we're training more physios, than we were 10 years ago when I finished the program. But even so, it's not that many, right? So we're not spitting out very many. The programs are so competitive. And so jobs are like, it just seems like the whole thing feels competitive. And yet there is an abundance of work. It's not like we can't like both have clinics and both be like it doesn't, you having a clinic doesn't mean that my clinic won't be successful. Like there is an absolute abundance of work, and yet we come in with this scarcity mindset, I think, because school is so restrictive as the beginning mentality of it all. And it's competitive, and it's like we compete for placements and practicums that are, supposed to be the best ones, and so it seems really competitive. But when you actually get out into work, it's like, no, 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 we actually all need to band together because there's A, not that many of us. And B, like if we want to actually have meaningful change in the profession, we have to work together. This is not a scarcity competition. And I do find it interesting because it feels like the UK puts out way more students. Like there's just way more graduates of programs across the country than there are in Canada.
I mean, you think there's probably, oh, I mean, it would be an absolute guess, but I'm going to say there's at least somewhere between 35 and 45 physio schools here, each with a bachelor's and a master's program.
Oh my God.
Um, yeah. So I would say there's, each school is probably pumping out 80, somewhere between 80 and 100 physios. But then you don't have a licensing exam. So how it works here is if you graduate, you're licensed. But we weed at the school level. So, like for my master's, for example, there were 60 of us that started, but less than 30 graduated. So,
Right.
they really wean people out for safe practice. So it's slightly different. But yeah, I mean, the amount of schools, the amount we're doing, like it's it's frustrating. That's one of the frustrating things coming back is, you look on Indeed right now and there's, you know, 30 openings in Victoria alone, let alone Vancouver Island, let alone Vancouver and the interior and then you got to factor in all the public sectors that are hemorrhaging for physios right now. I think UBC has done a good job in adding seats, but where I think BC could really up their physio game is by allowing UVic, Simon Fraser, those universities to have their own program. I mean, UBC, great in a pinch. We're hemorrhaging for physios. They put a site on the island, a site in Fraser Valley. That's faster than UVic building their own program.
Mhm.
But, you look at Ontario, they graduate some of the best physios in the country. You have to
Yeah,
look to why. They've got 6 schools out
exactly.
there. So it's
Exactly.
competitive. Um, they do a better job.
They don't have
UBC,
that monopoly on the education.
yeah, where UBC does. And we now take UBC students and, it's fascinating, I find, working with them. I don't get me wrong, they've all been absolutely lovely, pleasures to work with, super curious, super gung ho for the profession, like lovely to have in clinic, but they're just not at the same level as your UK students doing those same placements.
Really?
Because, like you said, UBC is so competitive to get into. A lot of those kids are doing bachelors of arts, bachelors of English. There's not a ton of them coming from a kin degree, which would be
Yeah.
the most relevant degree,
Yeah.
and then they're trying to slam a lot of education into 2 years and get them ready for in my opinion, a ridiculous exam. It's not a lot of time to teach them like critical thinking, think outside the box. And so you see them get stumped on things like, a patient comes in with 2 injuries. And it's like, well, I don't know what to do. Or, it's an elbow injury, but It's not tennis elbow.
It's not
It's not
classic.
it's not your classic injuries. It's like, well, what is it? And they just kind of start to really struggle, because they haven't, done that kind of critical thinking and that thinking outside the box. And okay, well, if it's not this, where do I go? What do I do? What resources do I have to figure this out? And so I find it quite interesting, to take on the UBC students. Whereas, internationally, that's how we get trained. We get trained very differently to UBC. We do something called problem-based learning. So each week
Mm.
we just get a problem, and you work in teams, and you have to figure it out. And that's kind of how I learned our entire degree. So, you don't learn everything. You can't learn everything coming out of university, but it sets you up with how to, you know, manage a patient and work well with a patient, and kind of not just, well, if it's not tennis elbow, I don't really know how to help you. Well, it's like, wait, well, what do we know? How do we figure this out? How do we work together? And that's not everybody.
Exactly.
I don't get me wrong. There's some fabulous students coming out of the
Mhm.
Canadian schools, out of UBC. It's just something I've observed to be very different.
Yeah. Well, and having gone through the UBC program, I did the kin degree and went into it. I was one of like a handful that had a kin degree. There was a lot of arts degrees, psych degrees, lots of science degrees. But yeah, like, and in that program, I felt so grateful that I had such a strong kin background because it was bloody hard, but it was so fact based. Like, it was like, here is pathology, memorize all these things. Here is anatomy, memorize all these things. Like, it wasn't this like create resourcefulness, like, figure it out type thing. It was very like textbook injury, textbook assessment, textbook this, because we were being taught to pass an exam, because that's how they got their accreditation, was because they wanted to know that we could pass this exam, and the exam was the gold standard. And so we were being taught this formula. Okay, when you walk into that room on the exam, the first thing you do is check the brakes on the bed to make sure that they're not going to fly away. And it was like, I like, that was literally like the first thing, is like, you safety fail if you don't check the brakes on the bed. So it's like, how many times is that actually going to be a thing? Like, of course, yes, I want to make sure my patient's not going to fall off the table, but that's just not critical thinking. That's a formula. Okay, great. Now you ask your subjective questions. Great. Okay. And now you assess for range of motion, and then you do the joint below and above. And you do, like, it was just very formulaic. And it was like, based on the subjective, it was like, okay, so we have a low back. Great. I need to do a neuro scan. Like, it was like all these like puzzle pieces that were like just formula following a flow chart. It wasn't like, oh, hey, you have a person in front of you. Let's actually interact with this person and learn about them and see if there's like, any sort of fluidity within which I can operate. And like, maybe I need to look at this a little more holistically and think about the person in front of me, and not the, examiner looking over my shoulder and making sure I'm ticking all the safety boxes.
Exactly. And it's just not physio. Like, I mean, we know the doctors do it. Let's be honest, we've all done it. Like, how many times do you sit there and Google stuff? Like, I don't think, like, I mean, let's all put our hands up. Everyone does it.
No shame.
But
I do it right in front of patients. I'll be like, let's Dr. Google this together.
exactly, there's no shame in that. And I just don't think the value at physio school right now is, where does your gastrocs muscle insert and originate? Yeah, no, don't get me wrong. I think we need to know that. But do you need to know it at the gross anatomy level that you guys are being questioned on? Probably not. That's something you can Google. Um, you know, how we look at a gastroc, you know, injury, or a significant tear, like, how are we going to manage that? Let's critically think that. Okay, like, a lot of times you get students in, or other therapists I've worked with, and it's like, okay, well, why have you given them jumping? And it's like, well, they're this week far from injury, so therefore we jump. Or sorry, run. They run. Like, why are you running at this point? They're like, well, this far out, we need to run. And it's like, okay, well, what do you need to do to run? Well, you need to be able to, do a single leg hop. Can they single leg hop? No. Okay. Well, probably shouldn't give them running. Let's go back even further. What do you need to do a single leg jump? You need to do a calf raise. Can they do a calf raise? Okay, well, that's where we're having issues. So let's work there. But it's that critical thinking. Like, let's break down the activity we need. What components do we need to operate that? And then how do we see that? I think some people get, and this is everywhere in the world, some people just get so stuck on, well, it's a MCL sprain and they are 4 weeks post. Therefore, we need to do this, this, and this. And it's like, well, you've forgotten that you have a person in front of you who is 6 weeks, postpartum and they're struggling at home with a baby, giving them squats and jumps off a box is not appropriate because that's
Totally.
just, you got to meet them where they're at. And so I find that quite interesting. I find English physios generally are much better at that because that's how we're
Mm,
taught. It's
yeah.
it's here's a problem. How do you go about it?
Break
You
it
know,
down. Break it
let's
down.
break.
Work backwards. Yeah.
Yeah. And let's put six people all learning the same thing, but with different experiences, different exposures. How are you going to go about it? What's important to you? What do we need to know about this person? And we all bring our different opinions, different backgrounds to the problem. And so you learn off each other and you learn how to step back, critically think, look before, going. Don't get me wrong, I love a protocol sheet. ACL protocol, I love protocols, but you
Yeah, and they
still have,
exist for a reason. Totally. There's
exactly.
validity within that, but you look at that sheet and then you look at the person in front of you and you adapt based on their needs and goals.
Yeah. And that's hard to be able to do until you're many years out of school if you're having to come out and pass this, very protocol, very formulated exam.
Yes,
Yeah.
exactly. Exactly. And that's just it. Like everything we're taught is with this caveat is like, so on the exam, this is what you're going to see, but in real life, this is what you're going to do. And like, I remember that so many courses and so many things, it would be like, okay, so on the exam, do XYZ. In real life, it'll be different. And you're like, so what am I learning?
It's hard. It doesn't give you value. I mean, what are you paying for at the end of the day? You're paying for letters behind your name so then you can go learn physio in your own time. Really?
Exactly. Exactly. And I am someone, and it sounds like you're someone who has continued to pursue education. And like everything I do in the clinic, I've learned in courses after. Like, yeah, my basic orthopedic testing, sure. Like I learned that in school and I can, use my clinical reasoning skills to figure out what is likely going on. But usually the thing that you diagnose is often a symptom of something else. Like maybe they're moving in a way that is like predisposing that structure to injury or whatever, right? So treating that injury isn't always like, and following the protocol for that injury isn't like, it might get better temporarily, but you need to look at the person as a whole and look at their movement pattern and look at their injury history because yeah, like maybe that ankle sprain from before didn't rehab well and that's the whole reason why they're getting low back pain now. And like, cool, I can give you all the like TVA activations in the world for your back pain, but the fact that you are walking awkwardly on that ankle is actually a bigger issue and is going to predispose you to continued injury here. And like that is just not something that we're taught in school. It's like they have low back pain, give them this, do them this. Like
Yeah. TVA.
yeah, yeah,
Yeah,
exactly.
exactly.
Oh my God. Right?
And,
And it's just not functional. It's not functional
yeah.
or meaningful, nor does it take their history and their unique nervous system patterns into consideration, right? Like every single person has a different movement pattern and different injury history and different component that's going to affect the way their body is moving and create these different pinch points and injury areas. Like it's just, yeah, I have a lot of feelings about that.
Sounds like we're on the same page. But yeah, so I mean, it's a hard one, I think until we change the exam process, licensing process, that's not going to change. But also we need more schools out
Yes.
here, you know, more physios, more competitiveness. You need that out here. We're too monopolized out here
Yeah.
on the West Coast for a lot of this
Yeah.
stuff to change. So yeah.
Totally. I
I
agree
mean,
with
yeah,
you.
like I said, UBC's done a great job, but you know, what are they at now? 120.
I think
I think
so. Yeah.
they're at I think they're at 180 with the Victoria and the Fraser Valley sites now. 180
Okay, so
maybe.
there was only 80 when I graduated. I graduated in 2014 and there was only 80 of us that were, and I was the very first cohort of the Northern and Rural program out of, so we still were out of UBC, but they were trialing some like conferencing with UNBC. So we did some time in Prince George.
Um,
But we were a group of 15 within the 80. And I know beyond that, they've kind of like expanded into other locations. But again, it's not other schools developing their own curriculum. It's UBC just using satellite locations essentially.
yeah. And they've gotten them up very fast, and we should be thankful for that because, I think, no, I think it's 140 because I think UBC is 100 now. And then you've got 20 for Simon Fraser, 20 in Victoria, 20 in the
Yeah.
north. So yeah, 60, 160,
Yeah.
something like
Or yeah,
that.
maybe
Anyways,
it's still like 80 at UBC. Yeah. Anyway, I think it's definitely
something
more.
like
And they've done a great job of expanding it. But yeah, like another huge limitation that we're walking into right now is the college has canceled the interim license. So attracting international students is like, if I'm coming from the UK, why am I going to go to BC if I can't work under an interim license? So now you have, a 6 to 12 month period where you cannot work. So guess where they're going to go? Ontario, Alberta, like Nova Scotia, where they have an expanded scope of practice now. Like we're totally kicking ourselves for like we're not going to be able to attract these international students now because this interim license is gone, and that is another huge hurdle that needs to be resolved like ASAP in order to attract more physios to the province.
and I interviewed 2 physios like last week, and they had international physios, phenomenal physios, great physios, worked for years. They'd be an asset to the industry. But as soon as you tell them, the license pathways about to change, because CAPER released their announcement that it's all changing in January. We're going back to one national exam. So that's a big change.
Okay.
You've got no interim license. So, there's no incentive for them to be in the province until they actually are licensed. So that's another hurdle that we're dealing with, which only hurts us. And, the PABC again is doing a lot of advocacy around this, but the college is firm. They do not want an interim license, which is frustrating, which means we just need more exams. Like we need to be running more exams. Like the 2 I interviewed
Exactly.
last week, they're more or less ready to go, but the earliest the exam they can do is like January.
Yeah.
So, and now they're caught in that new license pathway because the fall exams are all really set for UBC, and it blatantly says they're set for UBC students. So internationals, like unless they're writing now, they're honestly not writing until January, February.
Next year.
Sorry,
Exactly.
February next year.
Yeah, which is wild. So yeah, then what happens? They move to Ontario. Maybe they had the intention of moving back to BC once they're fully licensed, but like life happens. Maybe they meet someone. Maybe they, it's the same as your story, ending up in Victoria and then deciding to stay, right? Like it's not this thing that is like, oh, they'll just go somewhere else and do their interim work there and then move back to BC. That's not a guarantee. So like that's not attractive to internationally trained physios. And I think that's going to be a huge barrier. And if the college is so stern on it, like that's obviously not going to change. And as clinic owners, that's really challenging for hiring. Now you essentially just have to, you know, hire
Wait
people
for
from
you
other
to
clinics or
or you're yeah or you're or you're stealing other physios from other clinics, which only hurts building that community. um
exactly.
Again, like in the UK, there's so many clinics that you don't see a lot of that. Physios generally move clinics, not always, but move clinics because personal situations change, moving, life changes, that kind of stuff. You don't see a lot of poaching, shall we say, of physios because there's an abundance of them. You don't
Yeah.
need to do that.
And like
Um,
that happens on the regular here. And there are clinics with reputations as being poachers and being, like that happens on the regular. And it's really, yeah, you're right. It hurts community and collaboration.
yeah, yeah, because then you know I'm sure you've had some physios poached, and now are you going to want to sit down and collaborate with those clinic owners? Probably not. And so it only hurts that, which again then only hurts us. So that poaching mentality, I'm just not here for it. I don't think we should be doing it. Um, you know, it doesn't help. And it's not helpful.
Yeah. Oh, I know. And we could totally go off on a tangent about hiring and about like making your clinic attractive to other people. But I feel like that's like a whole other conversation. Hiring physios, dealing with fee splits, dealing with like, other perks and things like that, and structuring that. That's like a whole other conversation. But I would love to do a 2.0 with you because I feel like there's so many more directions we could go. And we haven't even really
Absolutely.
talked about like your clinic and like leadership philosophy and like all of that stuff. Like I would love to dive into that. So let's hold that for a 2.0 for sure, because I think that's like a whole other conversation. But I so appreciate your views on expanded scope of practice because, in my opinion, physiotherapists are completely underutilized, especially in the public system. Like I work in the public system now. I've actually just recently started doing orthopedic assessments at the urgent care center, which is exactly where physios should be trialing being able to order imaging. And I also think like basic lab work, like basic blood work, is something that physio should be able to do too, even though that's not within our diagnostic wheelhouse. But just like getting the ball rolling on, basic labs, I think would be also a really helpful thing for physios to be able to do instead of having to send back to a doctor. But yeah, it's an interesting setting. Like I really think physios in urgent care were like, it's amazing. They're triaging anything orthopedic to the physios. So I'm doing, but then what happens? Oh, you might need an x-ray. Oh, I think you maybe are disky. Like, let's see what's going on here. Like, oh, back to the GP. So it's, now they've actually made
How
it
are you?
redundant because now the physio or the GP could have just done that assessment in the first place. The physio's done the assessment and now they have to go back to the GP. So now you've paid two people to do the same process. So there is a breakdown there, absolutely. But it is interesting because this is like one of the areas that I feel like physios are actually being utilized in their capacity. But there's so much more potential within that for use, right?
Yeah. Yeah, exactly. And not to like we do have public physios working in emergency. Like I think everyone says, "Oh, we need to put physios in emergency." They are there. They do exist. VHA has them, but they're working in a different capacity. They're working on, you know, mobility. The diagnostic component has already happened. And, is this patient safe to go home? Is this patient mobile enough to go home? Like, are they safe? Which don't is a valid and very important reason to have them operating in the emergency room. But
Absolutely.
yes, we need to be putting physios in emergency room, in urgent care, taking on that MSK component, as well as putting them on the 911. In England, we're on 911 as well.
Really?
How many people call 888 or 99 or 911, for musculoskeletal reasons? And if the person on the line can't be 100% certain, I mean, if you've ever called 888 or 111 or whatever it is here, I always get can
811. Yep. I sliced my finger really badly last year and was bleeding everywhere and was like, should I go get stitches or can I do this at home? And they were amazing. It was so wonderful.
so it's underutilized. I always get the UK and the Canadian numbers mixed up,
Yeah.
but underutilized. But I mean, I've called it before for various things, and 9 times out of 10, they're like, go to emerge because they can only help so much. So again, if we had physios sitting on those lines, but again, then it comes back to we need to be licensing more physios because you need to have
Those
an abundance
jobs.
of
Yeah.
physios, those to then want to do those jobs.
Exactly.
There's so many places, fracture clinics, emergency rooms, urgent care, 911. Like there's just so many places we can be, injection clinics, right there. There's another huge one that could be saving tons of money. Um,
Yes.
but yeah, until we can do diagnostic scanning, this is going to be a massive barrier. And in my opinion, until we pay our doctors differently, it's going to be a problem. At the minute, our doctors are fee for service.
Exactly.
So they
So
like
as
the
soon as
sprained
we cut into
ankles.
that, yeah,
They like
that's
the
taken
sprained ankles.
away.
They're easy. It's not like dealing with somebody on an opioid crisis that's homeless that they now have to figure out what to do with.
Exactly. Or the
Broken
multiple
arm is
comorbidities and yeah,
lovely.
exactly. Yeah. Yeah.
So, until we pay them an hourly or annual fee, we are going to be up against it with the doctors because, that's easy pickings for them. And I've had that conversation many times with doctors, and they see the value in physio for sure, but they will openly, I have a few friends that are emergency doctors, they will openly admit, they don't want to give up the broken bones because it's
Totally.
easy. The back sprains, it's easy. But if we could be weaning those out of the system for them, that can only help the medical system. But
100%.
there's a lot of work to be done for that to happen.
I agree. We have an uphill battle, absolutely. And I think a lot of it is proving our worth, proving our value, and proving it in a way that like has financial data behind it. I think that really is the big ticket. Um, Thank you, Cassie. This is like so great. I love your insight. And I think it's really cool that you have such thorough experience in the UK system because, it's easy to talk about like, oh, other countries do this, other countries do that, but you've lived it. You've lived and breathed it. You've gone through that system and you're working in the system and you know them both so intimately. So to be able to have that like super strong comparison and that ability to see the weaknesses and to see the strengths in both systems I think is really valuable. So thank you for all the advocacy work and all the heavy lifting that you're doing. It's not easy. It's also like free labor when you're doing advocacy work. It's like it's a lot, and I think it's really important work though still, right?
Yeah. I mean, if we want to move forward as a profession, we need more people advocating for the profession, more people stepping up. And, as awful as the Blue Cross audits were, and as awful as the ICBC stuff that's going on now is, there's a silver lining to it. It's forced a lot of physios to step up and to create these teams and task force that we're doing at the PABC to push advocacy, to push negotiation skills with ICBC, to push the boundaries of what we're currently doing. We were very status quo until these audits started happening, you know,
Exactly.
and there was a lot of
Exactly.
question, like if you read the fine print, what we were doing, what the profession was doing, it was in there. We can't really fight those audits. They're valid to be happening, but I think they're great. And there's a lot of clinic owners, who've had a lot of hard times because of it, would probably very much be offended by that comment. But and that's fair. But, if anything, it's helped build a community. It's helped bring physios together. It's
Absolutely.
helped strengthen the PABC. It's helped our advocacy. And so I think, you have to go through a bit of turmoil to see growth.
Absolutely.
And I think this is where we're at
Absolutely.
right now, is we are going through our tough time to only help push us forwards. So it
Yes.
sucks. It sucks for a lot of people, but I think it's good.
But you're right. We wouldn't be having this conversation right now if that hadn't happened. Like these things would not be mobilized. Like and physios as a people are generally very easygoing. Yeah, that works. Cool. Whatever. Status quo. Like very nice, easygoing, wonderful people. And so to see them get more engaged, I think is huge. Like it takes a lot to get physios riled up. So I like it.
It's good. It's good. I mean, I think it's great, and we need to keep the momentum and, keep pushing forwards and, cutting through all the red tape. And the more physios we can add to the bandwagon to help with this advocacy, the better. The feistier, the better. The more, the better. We got to keep pushing. So, I unfortunately I welcome the audits.
And like insurance companies have every right to do that. Like there is, like it's an absolute like necessity for them. They don't want to be paying for unnecessary treatments. And I agree. Like I think there was a lot of people who maybe not intentionally, like we're not intentionally, fraudulently billing companies, but they were just doing it because that's what other clinics do. And it was like, okay, yeah, so yeah, but like not reading the fine print. And like the PTSW conversation was different. That was not in the like public facing information. That PTSW was not able to be used. And that's where obviously the legal battle was happening. But aside from that, like you're right, the scope of coverage was not unclear. It just was like being like no one was even reading the T's and C's because like that's just how clinics operate and that's just what we do. And like, oh, they're doing it great. Or like it was happening at the clinic I used to work at. Cool. I'm going to build that program. Like no one dove into those T's and C's. And a lot of people got burned as a result of it. And, I think we're going to be better for it. And you're right, we're going through the hard time right now, but I think the future is really bright for our profession.
Yeah. I would agree. I would agree. And
Yeah,
the more community we can build, the brighter that's going to be.
exactly.
Yeah.
Exactly. I think that's a fantastic, optimistic note to end on. So, Cassie, thank you so much. Again, like open invite for a 2.0. I think we have way more to continue to jam on, but this has been a
Place,
really
you let me
fabulous,
know. I'm happy to.
amazing. Well, thank you so much. We'll chat soon.
Excellent. Nice to talk to you.
That's it for this episode of The Health of Business. If you're navigating any of these challenges in your own clinic, know that you're not alone. If you're interested in working together on any of these challenges in your business, head to danielleboyd.ca to learn more about my consulting offerings and to get in touch. Catch you next time on The Health of Business.